Today I'm going to talk about spinal AVMs. These are things that you guys need to know about because we often get referrals for patients who have been operated on for lumbar decompression, etc., because they've missed the diagnosis. So that's going to be the focus of the talk. So we're going to describe a classification scheme for shunting type vascular lesions. We're going to go through the vascular anatomy of the spine and spinal cord and talk about some imaging characteristics of spinal AVMs. And discuss some treatment options, and then finally wrap up with a couple of things on, or a couple of case examples of preoperative embolization, which is something that we do a lot of here for spinal cord tumors or vertebral body tumors. Classification systems, like everything, if you want to be famous in neurosurgery, you have to come up with a classification system. Sometimes they become a bit more cumbersome with each iteration, and they can be based on histology, pathophysiology, or anatomic location. The two most common systems are from Spezza in 1992 and 2002. The old system is quite simple, and we'll be going through using that system, type 1, type 2, type 3, type 4. That's kind of easy to remember. The new system is a lot more complicated and a lot more detailed, and I'll be sticking to the original system for obvious reasons. So this is the old versus the new. We'll stick with the old. It's a little bit easier to kind of wrap your head around because these things can be a little complicated. We're going to go through the vascular supply to the spinal column. Dr. Shaffrey used to talk about the back muscle as residence. There is not just one back muscle. There is not just one artery to the spine. It's important to know where the arterial supply of the spine comes from, where the watershed zones are, what the different areas are that you have to be thinking of when you're doing different sorts of surgery, whether it be vertebral column resection or lateral approaches and so forth. So what we have with the arterial supply, we have radicular arteries. They're the segmental levels that go across the nerve roots and dura. They're called radiculomedullary if they go to the anterior spinal, and radiculoperial if they go to the posterior spinal. If you remember one slide from this talk, this is probably the slide to remember. The anterior spinal artery comes from the radiculomedullary branches, from the vertebral artery, the ascending and deep cervical in the cervical region, and the thoracic and lumbar segmentals all contribute to the anterior spinal. The 6 to 10 branches, including the artery of Adamkiewicz, which we'll talk a little bit more about later, and there's also the artery of cervical enlargement, which is usually around C5, C6, which is important. The posterior spinal arteries, 10 to 20 radiculopeals, and they're off the midline, and that's how you can tell whether something is the anterior spinal or the posterior spinal. If it's in the middle, it's the anterior spinal. If it's off to the side, it's the paired posterior spinals. This is just a cartoon showing that in the middle, in the anterior aspect, that's the anterior spinal, and then the paired posterior spinals, which come off bilaterally at the back. The artery of Adamkiewicz, it's important to realize it's usually at T9 to T12 on the left side 75% of the time, but there is variation as shown in the figure. This is particularly important when you're doing thoracic corpectomies and so forth. We often do a spinal angiogram with marking of the level for particularly mid-thoracic lesions, so that when the guys go to do a big corpectomy or fusion or whatever, then they can see what level they're at very quickly on the Jackson table, because we've taken biplane images in the angio suite, which is better quality than the C-arm. It also helps because sometimes they'll do the corpectomy from the other side of the artery of Adamkiewicz. So if you know where it is, there's always a small chance you could injure it, and so going from the contralateral side can decrease your risk a little bit if you get into trouble. The vertebral bodies themselves are supplied by the posterior central arteries. This is important for the spread of metastatic disease, and of course the venous drainage of the spinal column itself is rich in blood supply, with the Batson's plexus supplying the spinal column itself. Sorry, go back. In terms of the watershed areas of the spinal cord, this is really important for long spinal surgeries where the blood losses a lot. So it's the cervicothoracic junction, the mid-thoracic area, and the thoracolumbar junction. And so particularly after long deformity surgeries, a lot of blood loss, drop in blood pressure, and so forth, these are the areas where you're going to get your spinal cord infarctions. And so it's important to keep your blood pressure up, keep your maps up, and if the blood loss gets too late, then or gets too high, then stop, because these are the areas that are going to get watershed territory infarction. Just going over the normal anatomy again, you've got the medullary arteries and those radiculopeals going to the back, the posterior spinals. So now what happens if it goes wrong? It's important to recognize these mostly rare problems because you don't want to operate on them without knowing what you're getting into. The most common type of vascular lesion we see in the spine is the dural AV fistula. It's about 70 to 80%. And what we can see there is that the fistula is actually at the nerve root sleeve, and the draining vein is just inside the nerve root. It can have single or multiple feeders. It's really important to tease that out because if you only take the single or one of the two feeders or multiple feeders, you're not going to cure that lesion. So initially, the patient might get better, but then it will recur. So it's important to tease out whether there's multiple feeders. The features, this is kind of classic 40 to 6-year-old male. It's a slowly progressive lesion. They get leg weakness. Then they can get incontinence of urine, back or radicular pain. Worst case scenario is the subacute necrotic myelopathy. But this is also really difficult to tease out compared to just spinal stenosis or routine kind of degenerative spine that you see in the clinic every day. And this is particularly why we often see these patients after they've had a lumbar decompression, because the diagnosis is not made and it's treated as spinal stenosis. So what do we see on imaging? 94% get a central T2 hyperintensity. The serpiginous vessels is common but not always there. Cord swelling, patchy or diffuse cord enhancement are the main ones. Myelograms, you guys don't really see that as often, but you can see here this is misdiagnosed and had this extensive fusion put in when it was actually a dural fistula. Not good. So you can see on the MR, in the T2 in the middle column, there's T2 hyperintensity indicating cord swelling, and it's a little hard to see on this projection, but there are little vessels or flow voids you can see on the far right of the screen. Here's just another example. If you look closely at the spinal cord in on the T2, you can see that these flow voids here, and that's from the dilated veins. It's not the arteries, it's the veins that you're seeing. So again, do not confuse the dilated veins you see in a bad back with the dilated veins you see in a dural fistula. And here's another classic example, lumbar decompression surgery, patient doesn't get better, everyone's scratching their heads until somebody makes the diagnosis, and here's just a couple of examples there. When we do an MRA, we can see, often we can pick up with time-resolved MRA, we can see the fistula. Here's the 3D, you can see just at the top with the vertebral arteries, there's a fistulous portion there with a large draining vein down the middle of the spinal cord. So angiography, second key point, that's the modality of choice to make the diagnosis and also to aid in treatment. The thing with dural AVFs, usually they're single feeders, but they can be multiple feeders. The nidus is at the intervertebral foramen. I'll show you a picture of that in a second. The intradural draining vein is the tortuous part. The vessels are generally straighter, and the vein is the tortuous part. So when we look at this example here, we can see I guess it's not going. We can see here, this is the fistula right here, and this is the draining vein. You can see on the unsubtracted view that the fistula is right at the intervertebral foramen. So that's where you find these things. They're kind of the easiest fistulae to treat surgically, because if you find the foramen, you'll find the fistula. And here's another example again. You can see the tortuous draining vein, which is that snake-like structure, and the fistula is right at that point where it changes from a squiggly line to the right here. And again, this one, multiple feeders, and this one, the fistula is right here. So again, look at the vessels. It's important to look at all the vessels. This dural fistula was fed from an internal iliac branch. So we don't always look at all the vessels routinely, but with spinal AVMs, it's important to check absolutely everything. If you don't look, you won't find. The differential diagnosis, cord infarction, MS, transverse myelitis, all those other nasty sort of neurological diseases that we don't typically see. And here's an example of spinal cord infarct. It looks pretty similar with the T2 changes. The key thing with treatment of dural fistulas is you have to occlude the vein. Whether you do that with surgery or with embolization, if you just take down the arteries, the fistula will come back. So at surgery, we have to divide the vein. With embolization, we have to make sure we penetrate through the arterial phase into the venous pouch or the venous part of the fistula with onyx or glue. NBCA is a glue that we used to use. We use a little bit less frequently now. It's adhesive, so it sticks to catheters, whereas onyx is what we call cohesive, so it sticks to itself. It kind of moves like lava, and it doesn't get stuck to our catheters, so we can do embolization over many, many minutes or hours without the catheters getting stuck. It's important, particularly with embolization, that we don't embolize the anterior spinal, so we always check what vessel we're in and what it's supplying before we embolize. Go ahead. I always check them again at 3 to 6 months. So the nice thing is you do an MRA and an MR with T2, and you'll see that the serpiginous vessels will disappear. So that gives you a bit of confidence, but typically at 3 to 6 months we'll do a follow-up angio and make sure it's gone. With type 1s, it's debatable whether you need to do a follow-up angio if the patient's symptoms have gone. If you lose all the T2 signal on the MR, then there may not be a need to do that because the patients typically, if they're getting better and all the T2 signal is gone, you know you've cured it. At surgery, we have to divide the draining vein, as I mentioned. Here's an example of a subarachnoid hemorrhage with a vertebral fistula. If I could we get another pointer by any chance? Oh, let's see if. Okay, well, there's a fistula just at the vertebral artery, just here, and that was divided with surgical clipping, and you can see that the draining vein is gone on the far right panel. This is an example of a surgical dissection with coagulation of the draining vein. I think Dave might have showed this case before, but this is the dural fistula. You can see the nerve root coming in, and then we just identify the vein. You can see the vein on the back of the spinal cord, and notice that it's bright pink. And once we're done bipolaring here, then it will become purple. And these cases are really straightforward surgical cases. As long as you find the right level, then the rest is pretty trivial. So once we've bipolared it, then we can cut it. You can see already that the fistula or the venous drainage is becoming more purple. There we go, that's the end of the case. And then with the ICG, so we do indocyanine green video angiography. You can see the early draining veins here. There's nothing on the spinal cord is lit up yet, apart from the early draining vein. So this is given peripheral indocyanine green with ICG, and you can see now that it's lighting up on the spinal cord itself. But we had that early venous drainage with the fistula. And once you've taken care of the fistula, what you find is you get stagnation of ICG in that vein. It doesn't wash out like it would if it was still open. Here's an example of embolization and just what I was talking about with the resolution of the T2 signal on that MRI on the right side. You can see the serpiginous vessels are gone with the embolization, this time with NBCA, which is glue. So there's different results depending on which one you use. PVA was the first, or particles was the first thing that was used. Problem with PVA, it's like sand, and we can get sand in different size vials, but the sand kind of dissolves, or the particles dissolve, and the fistulas come back, the fistulae come back. NVCA is a little bit harder to use now that we have Onyx, but it can be very effective. With Onyx now, depending on the case series you look at, most of them are pretty small series, you can have up to 100% cure. So if you're selective about who you treat with Onyx, you can get really good results. With surgery is really easy, and the results are fantastic. So it's really hard to argue, unless someone's not fit for an operation, that we shouldn't do surgery on these cases, because it's really straightforward, as you saw from the video. Moving on to spinal AVMs, they're a little bit more complicated. They're much more rare, 15%. They're high flow fistulae. They can have aneurysms. They can present with hemorrhage, which is common presentation, cord compression or cord ischemia, mostly in younger patients, and they can be found throughout the cord. Compared to the fistulae, which we just talked about, tend to be older patients, males, and usually in the thoracolumbar junction. So the glomus, or type 2 spinal AVMs, they're congenital lesions. They present with young adults, often with hemorrhage. Cervical and thoracolumbar are most common. They have a high mortality rate, 18%. The rebleed rate is high, 10% in the first month, 40% in the first year. So these are lesions that really have to be dealt with. Here's an example here. Again, the serpiginous vessels, but this one's actually inside the spinal cord with a compact nidus. This is just a cartoon kind of demonstrating that. You have one big feeder coming in here, then you have this very compact nidus, and then the venous drainage with the serpiginous vessels again. On the myelogram, you guys don't see as many myelograms anymore, but you can see the serpiginous vessels in the spinal fluid space. Of course, doing a myelogram on these patients, you just want to make sure you don't hit one of those vessels. With the MRI, again, you see the T2 signal change from swelling, hematomyelia. You can get intramedullary hemorrhage. You can also see the flow voids, and on the GRE, here you can see this is a significant amount of hemorrhage. You can also get contrast enhancement. It's important to tease out whether this is a spinal AVM or whether it is a contrast-enhancing tumor like an ependymoma, hemangioblastoma, or an astrocytoma, for example. Here's just another couple of pictures. You can see the spinal AVM type 2 right in the middle of the spinal cord, making these particularly challenging lesions to take care of surgically. The treatment is either surgical or with stereotactic radiosurgery. Here's another example of glomus on time-resolved MRI. That's probably the modality of choice. We use a TRIX protocol, MRA, and that's pretty good at picking these up. So again, the intranidal aneurysm is something that we want to look for. I'll just show you a couple of examples of what the angios look like. So you can have multiple or single feeders. The one on the left is a single feeder, and then multiple feeders on the other two. Multiple feeders makes it a little bit more complicated to take on endovascularly. Unless we can get into all the pedicles, we're not going to be able to completely treat that AVM endovascularly. Similarly, we've got to look for intranidal aneurysms. If you have an intranidal aneurysm, it significantly increases your risk of rehemorrhage. And what we can see here, you can see right at the base of that AVM, there's a large dilatation. That's an intranidal aneurysm. And that portends to a poor prognosis. You've got to see all the arteries. So when we do the angiography on these lesions, we have to look at everything, because what you don't want to do is take out that AVM, and in the process of taking it out, take out the anterior spinal. So you can see in the third panel, you can see there the anterior spinal loop, the hairpin loop of the artery of Demkiewicz coming up. That is not a vessel that we would want to take in the process of taking out this AVM. Type 3, these are really rare. You're never going to see one, but we put it in the talk so that you can say you've said it, or say you've seen it. When spinal AVMs take out the whole metameric segments, that means the bone as well as the dura, and the spinal cord in that one spinal level. We call that Cobb Syndrome. That's a special subtype of the juvenile or type 3 AVMs, and you get enlarged feeding vessels from pretty much everything, both intra and perimedullary. It's usually in younger adults, and this is just an example of that on MR. And another one. The juvenile AVMs, they're the ones that fill up basically the whole spinal cord. Again, these are really rare. You probably will never see one. Here's an example of a juvenile or type 3 AVM. They're filling up the whole spinal cord with intervening normal spinal cord. So in terms of surgery, they're not surgical candidates. You're going to end up paralyzing people. The last one, again, rare, but important so you know about it, 5 to 10%. The perimedullary fistulae, so they don't have an intervening nidus. They basically just go from an artery to a vein on the surface of the spinal cord. They are commonly in younger adults. Again, they're rare, 5 to 10%. And you can see there on the cartoon, there's no intervening nidus. This is just another representation of that. If it's on the anterior side of the cord, we tend to try and embolize those. Surgically, they're really hard to get at, and they often involve the anterior spinal, which makes surgery even more difficult. If they're on the posterior side of the cord, then often they can be dealt with surgically because you can see them, and you can see that fistulous point where it goes from an artery to a vein. But again, they're pretty rare. I'll just skip through the CT pictures. Here's an example with the MRI again, large flow voids. We go on, do our MRA time-resolved sequence, and you can see where it goes from a straight vessel, there's an arterial segment, and then all of a sudden it gets fat. That's the transition point, that's the fistula. So it's important you don't just buzz the whole vein up the spinal cord. That was kind of the old way of treating these perimedullary fistulae. If you didn't know where the fistula was, you would just bipolar the whole back of the spinal cord on that dilated vein. Now, if you're lucky, you would take out the fistulous portion at the same time, and so a lot of the time that would work. But the key thing is taking that fistulous part where it goes from the artery to the vein. If you take that, then you'll be successful. And again, here you can see where it goes from artery to vein. The vein is that dilated portion. If you take out that part there, that's all you need to take out. You don't need to go buzzing the whole vein. So in terms of treatment, Yaskell treated 41 patients as an old series, 60% removed, 12% stabilized as subtotal resection. Santa Connolly had a larger series for the type 2, 94% initial angiographic cure, but 23% developed new venous drainage on follow-up angio. So it's important to follow these patients initially with MR. I typically follow with MR long-term, and then an angio at 3 to 6 months. And then if something changes on the MR, then I will do another angio, or if they get recurrence of their clinical symptoms. Long-term angiographic cure is high, 80%, but there are neurological deficits. 30% get a chronic pain syndrome just from operating in the spinal cord. In terms of type 4 AVMs, these patients do pretty well, particularly if they're the dorsal lesions, because surgically those are much easier to get at. If they're ventral, then you're really kind of limited to embolization, because it's a little hard to get around to the front part of the cord. We don't really know much about type 3 cases because they're just so rare. So in terms of endovascular for type 4, now with the Onyx, we're getting better and better. We have detachable catheters, so like a lizard's tail that leaves itself behind, we have catheters we can leave the tail behind. We have balloon catheters and all sorts of little tricks that we can use to get Onyx to places where we want without getting it to places we don't. So we're getting better and better, but about a 67% cure for type 4s. For type 2s and 3s, again, really rare lesions. It's mostly palliative treatment. This is an example of embolization. You can see there's one large feeder and then that nidus there, and this is treated with Onyx. And you can see resolution of the T2 flow voids. briefly mention this last one, just in case you see it. Again, it's rare, extradural AV fistula. So this is a fistulous connection between the arteries and veins outside of the spinal cord itself. So it's a branch or a fistula between non-medullary branches of the segmental artery and the epidural venous plexus. So typically in the vertebral region. It can be associated with trauma, but not always. If you listen, you might hear a bruit, but they can present with radiculopathy, compressive effects like myelopathy. In terms of treatment, it's rare. Biggest case series had 10 patients. Most of them do pretty well. Some were embolized, some had surgery. Embolization in this area is pretty safe because they're not going directly to the spinal cord. Those vessels can be taken down without as much concern. Just wanted to finish up briefly talking about presurgical embolization of tumors. Hands up who does this routinely for vertebrectomies for tumors for cancer. It's about half. And what about you other guys? You just get the blood bank on the phone and get a bigger sucker and go fast. So the whole idea is to decrease blood loss, the bloody tumors, things like renal cell, melanoma, decrease operating time, decrease morbidity. Rod likes to get as much help as he can get, so we have to tell him where he has to go. So we'll typically put in a radio-opaque marker, just a couple of coils or some onyx, particularly for mid-thoracic lesions. We have the coolest equipment with the biplane suite, and we can do spins and 3Ds and all sorts of crazy stuff. In the OR, we just have a C-arm and a Jackson table or an O-arm, etc. if you're going to use that stuff. But typically to get started, you just use a C-arm because it's fast, right? And so for mid-thoracic lesions, we'll typically put in a marker at one of the radicular levels and then shoot an X-ray of the whole spine so they can count lumbar levels and then thoracic levels, and they know exactly where they are in relation to that coil in it. So it just really speeds up that first 30 minutes of the case because you can just shoot an X-ray, see the coil, put your incision line over it, and let's go. In terms of the side for the corpectomy, I mentioned if you know where the artery of Denkiewicz is, that's useful. You may do your corpectomy from the other side. We've certainly had cases where our surgeons have changed which side they've gone from based on that. The tools we have, we tend to use particles, glue, or onyx. When we're using particles, we embolize above and below the lesion that we're targeting. What we often find is that if you just embolize the level that has the blood supply, then you get increased hypervascularity above and below. So what our guys have noticed, at least anecdotally, is that when they do the incision, the areas around the tumor are really dry like chalk, and then further up they can get sort of venous engorgement and more bleeding because everything's redirected to those levels. So often if we're using particles, we blast it three levels above and 3 below, and that can really take down the blood supply. With onyx, we tend to just take out the level that's got the blood supply. Risks: access complications, so bleeding, damage to the femoral artery, hematoma. Most feared complication is a retroperitoneal hematoma, which can be life-threatening. That's rare. Stroke of the spinal cord. So again, you really want to know what you're embolizing before you put a big gob of onyx in there. You don't want to embolize the anterior spinal. So typically we'll do the full spinal angio, find out where everything is that matters before we go and embolize. So you feel a lot better about putting an onyx once you know where the anterior spinal is. And of course, neurodeficit resulting from embolization of a critical vessel, similar to the ASA. If you take out a large feeder, you can get a neurological deficit. One of the things we can do is what we call a super selective WADA test. So we can inject amytol into the, or amytol-like medications into the spinal cord, kind of like we do with the epilepsy cases, to basically numb out that vessel's blood supply while the patient's awake, and get them to do stuff. Can you still move your legs? And if the answer is yes, squirt on some onyx. If the answer is no, then get out. So this is a couple of case examples just to finish up. You can see just where the microcatheter is, or where the guide catheter is, there's kind of a blush. We call that a tumor stain or a tumor blush. And when we've taken that down with Onyx, you can see it disappears. And this is a relatively straightforward thing. It takes us about 10-15 minutes to do. Similarly here, this is another case we did for Dr. Chapman. You can see a pretty generous tumor blush with that initial angio on the top left. And then after we put a gob of Onyx into that feeding vessel, and the unsubtracted view is down below, all that black stuff is Onyx. So we've pretty much taken out the whole blood supply of the tumor. So when they get in there, they're just taking out a kind of a carcass. There's nothing left. And finally, this is a much more complex case. This is a renal cell case of Dr. Chapman's. And you can see there's multiple areas that are lighting up on the spinal angio. And so what we did is we onyxed 7 or 8 different feeders to that, and you can see how kind of white it is in the bottom, without wishing to go into the details of each vessel that we took out, but there's a hell of a lot less blood supply going to that now, which allowed him to do that. And the blood loss was less than 500 cc's for a renal, which is kind of nice. So just to finish up, non-invasive imaging is really important. Angiography is the gold standard. If you see serpiginous vessels or a T2 signal intensity with serpiginous vessels, you need to do some angiography. MRA is probably a good place to start, and if that's negative, then sometimes we go on and do an angiogram. You really don't want to miss this stuff. It's a really good way to be ending up and talking to the people with expensive suits about why you did a laminectomy on a spinal AVM. Again, correct angiographic protocols. We have to be careful when we're doing angio. We have to be careful when we're embolizing. And finally, consider preoperative embo for all your large oncologic tumors or bloody tumors to make your life a heck of a lot easier. I saw lunch roll by, so I think I'll finish there. Any questions?